So now I just want to open up the floor for any questions for any of our panelists.
So actually my question is, we're all here because we're passionate about what we do and working in this field. What are we doing for the people that aren't as passionate about what we're doing? So what are we doing to educate the primary care physicians that are out there that are over-prescribing medications or don't understand what an addict looks like before and after treatment and recovery?
That's an excellent question. Are there any more questions? Okay, so I used to be a DoD financial manager. One thing I learned that whenever you get a grant like this, the first thing you do is break open terms and conditions. So reviewing terms and conditions, we are restricted from engaging providers during the scope of this grant. We're also restricted from engaging insurance companies. However, we work very closely with a lot of partners that do. And it is a concern as we look at what we're doing here. It's more than just being tactical. You really need to be strategic, and you need to think about what we're doing here as a campaign. One of the things I didn't mention during this presentation is there's a lot of people were still wrapped around we didn't expand Medicaid, and now you're having people apply for coverage that they can't afford. What we did is we still encouraged people to apply. And a lot of people elected not to get that coverage. But the reason you want to do something like that is there's 1.6 million people in North Carolina that are uninsured, and legislatures can stand back and say, well, we don't know what it's going to cost to solve this problem. Here's your first step. Now I gave you a price tag. Okay, these are the people that want coverage. This is what it is. They can't afford it. So now pay for it. Here's the number. So if we think about this as we start engaging providers, I think we're saying a lot of things to people that work in the recovery field or providers that work in recovery that already understand this. But as this becomes part of a greater conversation and we start looking at bundled services across the continuum, we're going to bring more and more of those partners on board. Everybody's talking about integrated care now. And so we're going to be at the table for that. So.
Anyone else? Great.
Okay. My name is Regina Penna. I'm the Project Assist Coordinator for New Hanover, Pender, and Brunswick counties. I do tobacco work, and that's the one thing that I haven't heard anybody mention on this. And I was at a conference a month ago up in Raleigh that was on mental and behavioral health communities, and really encouraging them to include tobacco as part of the continuum of care that you're providing for your clients. There's numerous studies that have shown that if you treat that as part of the whole addiction spectrum, that your clients are going to be much more successful in truly gaining health. Rather than allowing it as something that you're just going to kind of clean up on the other end. Also, when you're talking about people who are economically depressed, if somebody smokes a pack a day, and chances are your clients are smoking a whole lot more than that, a pack a day is $1,700 a year. What could somebody do with $1,700? Okay, and a lot of work sites are now adopting tobacco-free policies, requiring their employees to become healthy just because it costs them less for health insurance, even for part-time employees too. So getting somebody clean and healthy from the get-go is really important. I have materials here on billable, the Medicare billable code. So if you have somebody who is in there, they have a provider who's doing counseling with them, it's a billable event to talk to them about tobacco cessation. And if someone is underinsured or uninsured, who the majority of our 20% of North Carolinians who do smoke are underinsured or uninsured, people of color who are uneducated too or undereducated, they can call the quit line, which is free, and I'm real big on free. And for people who call here who do not have insurance, they provide free nicotine replacement therapy for them too, and telephone counseling. So that's just another added service to be included on the continuum of care. So that's my unpaid political announcement.
I think you make a great point, and we will definitely, if you want to set those out on the table, and we can grab. Does anybody have a response?
So we also have a separate SAMHSA grant, Peer Recovery Center. As part of most of these SAMHSA grants, smoking cessation and a trauma group actually are part of this grant. So it's an important component, and I certainly agree with you wholeheartedly. One thing is if you do the application, and and if you have health insurance, I would encourage you to go through the application process under the Affordable Care Act, just because I think it's kind of an interesting exercise. I went through it myself, and you'll find that first, smoking is one of those things that significantly affect your premiums. And as you're talking to a consumer, and you look over and say, hey, you know what, this is what it would be if you didn't smoke, but this is what it is. And some navigators got in trouble in Texas by saying, well, lie about it or whatever. And so it didn't really work out really well for them. But we encourage people, to look at those premiums and see what the difference is between the two. A very, very important point.
I'm Ann Doolen. I'm the Executive Director of the Alcohol and Drug Council, and these folks have been doing really, really incredible work, and I'd like to thank the woman who brought up the issue on nicotine. I think that the whole issue of how to address and deal with nicotine, we as a field have been less than honest with folks about, and the degree to which nicotine is one of the most addictive substances that exists, and we continue to come in with interventions that I think in a lot of ways dismiss and minimize the seriousness of the addictive issues. We've done an incredible job in this country in a lot of ways of reducing nicotine usage. The folks that are left are folks who probably have a very, very serious addictive disorder, and that we have not developed, I don't think, the strategies that are going to be needed for addressing and dealing with the kinds of issues that folks who are still smoking are having to address and to deal with. I would hope that we who are in the treatment field begin to get some understanding that nicotine is in a lot of ways not any different than cocaine or heroin or alcohol, and that the folks who have developed an addiction to nicotine probably are deserving of some much more significant interventions than we currently make available. I will tell you that I am also a person who's in very long-term recovery, over 30 years, and that historically, the issue of dealing with nicotine has been really minimized. We minimize it in our recovery communities, we minimize it in our treatment programs, and we don't do a good job on dealing with it. And if we're really going to get to what are the real issues with recovery, that we as a field, and particularly our agency, is looking at this from an issue that people who have addictive disorders die 16 years earlier than the general population. We have life expectancies that are similar to migrant farm workers. And that's not just the folks who continue to use, that's also the people who are in recovery. And a lot of that has to do with things like nicotine. And a lot of that has to do with the issue of not being able to access health care. And I think that when we begin to look at addictive disorders and how we interact in the healthcare system, that we need to begin to look at all of those things. And I want to thank you very much for bringing up the issue of addiction, because I think we haven't minimized it.
All right, so we have a few more minutes. I'll entertain maybe one more question if we have it. Put anybody on. So we mentioned throughout the presentation several different services. You have this little half sheet in your packet. I just want to go over what services we have available at the Alcohol and Drug Council as far regarding ACA. So Nee had mentioned in his presentation the navigation line. This is based out of our main office in Durham. You can call us and we can link you up with a navigator. A lot of times it'll be me helping you out. Have consumers call that line. We can help with application questions, technical issues, helping you understand something about your insurance coverage, or link you with somebody that can answer those questions. We also have train the trainer presentations, and that's for navigators coming to your agencies. We can, once again, train your providers to help your consumers get through that process. So help you understand so that then you can pass the information along. We also do larger consumer presentations. That's more significant during an open enrollment period. Right now we're in special enrollment, but having a navigator come and talk to a room full of consumers and walk them through the process And then through that process, we can set up one-on-one appointments with navigators. Most of the time, there's a lot of complex issues going on, so we definitely want to hook you up with a navigator to work on that individually. This sheet is, like I said, in your packet. There's also more in the back. Please feel free to bring them back to your agencies, distribute them. We want this information to get out there. My contact information is on there if you want to set something up at your agency. We're happy to come out, and we do that statewide. So that is it. References, and our contact information is on there as well. Thank you so much all for coming. We are glad you were here.
Ideally, your physician already knows that you're in long-term recovery and that you've had conversations before with them about how, and strategies about how you're going to address a whole host of healthcare issues that can be impacted by the fact that you have some history with having had an addictive disorder. I think there's in general sort of the assumption, even among the medical community, particularly for people who are in long-term recovery, that their addiction is just not something that needs to be worried about, and that we just kind of fail to understand that this really is a chronic disease, and that my symptoms are sort of in recovery, but it doesn't mean that the disease can't crop back up, and that that you take the time to talk with your physician, and you have a physician that you're really comfortable. Try to find a primary care provider before there's an emergency. And now that a lot more of us can get health insurance, to have those discussions and find a doctor who seems to at least have some basic knowledge, or if that's not even the case, at least is willing to listen to you and to be able to honor what your history has been when they're trying to provide you with medical care, because both of you want the best possible medical outcome. And if you don't find strategies and understand that this is a chronic disease, you wouldn't not tell your doctor that you had a history of diabetes or hypertension. You probably ought to also be making sure that they have that knowledge, and that you, in fact, as a consumer, can do a lot for helping educate your provider about what your struggles are with this and what are the things that you need to be careful of. And being able to, I think, find alternatives to using pain medications or other anti-anxiety medications that are, in fact, less addictive. There are clearly going to be times in your life and your doctor that they're going to have to take some time and find those kinds of solutions. I know at one point I had shingles, and my doc was really good about sitting down and figuring out what were some of the things we could use to deal with the pain. There are other times that you may, in fact, not be able to find a good alternative and have to be on some narcotic medication. And for someone such as myself, that's a real opportunity for a relapse to come into full force, or it's an opportunity to deal with the pain and develop almost a relapse prevention strategy for the fact that I have to take this medication right now. What are some things and strategies that I can do with my doctor and with my support system to be able to use the medication for what it's meant for, but not also put my long-term health in jeopardy and reduce the chances of having a relapse. One of the really big problems with this disease is the guilt and shame, and the assumption that we, by our actions, were the sole cause of getting ourselves in with this illness. And I think that we all have an obligation to begin to relook at that. In a lot of ways, this is really not just a brain disease, but a metabolistic disease. Our bodies utilize and metabolize drugs and alcohol differently than it is for a lot of other people. And we need to remember that, we may very well be metabolizing other drugs differently too. So some things that might be very routine, if your doctor doesn't know that you've had an experience with an addictive disease, I think that as we get more sophisticated about how we provide medical care to everybody, there's so much individual differences that for the doctors not to have the knowledge of your having had an addictive disorder over the long haul is going to interfere with their ability to provide you the best possible medical care. And that sometimes we have reactions to medicine that are different than what other people have. And some of us have been starting to be a whole lot more open about discussing with each other what some of those things are, and going back to our doctors and going, I'm not the only one who's getting this side effect with this. And to be able to kind of share that, because it's all such a huge learning experience. It's a discovery, trying to be as healthy as we can, and that's a real partnership between you and your provider. And to not have that it makes it difficult, one, for you to get to where you want to get to, but it also makes it more difficult for the doctor to be the best kind of medical care practitioner that they can be if there's this big hunk of information they don't know anything about. I'm old enough to have remembered when I first got into recovery in my early 20s. There was still a whole host of people who honestly didn't believe that women could get addicted. That there was the assumption that there was something innately protective about being female that allowed that women did not get addictive. And women who used heavily, by and large, were defined as using the drugs or alcohol to treat something else. And we've certainly come a very, very long way in 30 or 40 years in terms of that. Women weren't terribly represented in the recovery community early on. There were certainly some prime examples, such as Marty Mann, but that it didn't have the kind of momentum that it may have had, particularly among men. And I think the result has been that a lot of the more traditional recovery and support systems for recovery tend to be much more male-centered. And I think that makes it a little bit more difficult for women to find some places and safe spaces to be able to talk about not just their experience while they were using, but also their experiences in recovery. And I think that there are, we touched upon some of them, we have different hormones, we have different metabolism systems, we store fat differently, we may in fact metabolize some of those drugs very differently. But I also think that there's the additional stigma and shame that are brought on about the issue of women who develop an addictive disorder, or the symptoms begin to show up on it. And that a lot of that has to do with the perceived behavior of women who are using. And it's much more sexualized than it is for guys. There's a lot more emphasis placed on sexual behavior when people are using, and you add that to the kind of guilt and shame that we put on all folks in terms of addiction. It makes it very difficult for a lot of women to kind of get out of the denial that this is what's happening to them. And that I think there's a couple of things. We as a larger society are less likely to identify women who have addictive disorders in early stages of the disease. A lot of us tend to use much more quietly and much less publicly than our male counterparts do, so that the disease can progress much more rapidly and get much more serious before it comes to the attention of other people that we're in a whole lot of trouble, and that we can get very, very sick before anybody thinks that there might be a reason to intervene and to get us into help. And when we get into help, very often it's not the kinds of things that we are really in need of in terms of dealing with our recovery. A lot of our roles and functions, in terms of how we've developed treatment systems and models, really interfere with that. I was very involved with developing perinatal addiction treatment services in North Carolina, and I know when we first got started, there were still a lot of people who believed that if women really wanted to get sober and really wanted to get clean, that they would leave their children in sometimes very precarious situations in order to get into the residential treatment programs. That flies in the face of what is being a good and responsible mother and adult, that you're going to put your kids in some sort of precarious situation to take care of yourself. That's not going to happen. We're not going to do that. So the ability to, in fact, have treatment programs that don't deny the kinds of things that women are supposed to be engaged in and doing, and rather than enhance those, so that the understanding that we are still going to be parents, we are still going to be partners, we are still going to be a lot of other things, and we have to deal with our addiction in the context of that, rather than to just deal with our addiction in a kind of isolated piece that we can just kind of go in and fix that, and then everything else will sort of magically get better, when in fact women tend to get better through that experience of developing the relationship and learning that process, and how do you in fact do the things that are expected of you while you're also learning how to be sober. The other thing is that depending on the situation, women very often have less recovery capital, and I become really interested in the issue of the kind of psychosocial supports people have in place and economic supports people have in place to be able to really engage in recovery. It's really difficult if you don't know where you're living, or if where you go back to is not safe. So for women who have been being abused while they've been using, the idea that they go back to a home that they may be sober, but there's still a lot of physical abuse going on, is not one that's very conducive for people being able to maintain their recovery for a long period of time. Do you have enough to eat? Can you take care of your kids in the way that you think is important? All of those kinds of things come into play when you're looking at recovery as opposed to the actual medical treatment for a disorder. One of the things that makes addiction different is all diseases have some sort of social, economic, spiritual component to them, but particularly for addictive disorders, because of how we've looked at it and how we've addressed it, there's been just an incredible amount of damage that gets done to those support systems. And how do you put those back into place for people to have reasonably fulfilling lives and be really competent members in the community? And you do that, and women very often have fewer of those supports over which they have any control. When we start actually being able to put those pieces together, so that women who are addicted or who are in recovery aren't being denied medical care anymore, simply on the basis of it being too frightful and too scary to see a doctor because you might also have an addictive disease and you are pregnant. And how are we going to address that and deal with it? The life experiences of women are a little bit different than men, and that we have begun to develop systems that address that. It's not available to every woman. I think particularly women who have some resources are less likely to be identified at this point, and are less likely to be accessing treatment, and I think that's of great concern to me. I think if you begin to see the increased usage, particularly of alcohol, among college-age women, and how that plays out and is used, we do know that women tend to get sicker and die earlier, or get much sicker from the drugs than men do, and that their trajectory on their disease is much more rapid. And it's of grave concern to me that the heavy drinking is being started earlier, and we don't know how that's going to end up playing out for a lot of those women.